I'd like to introduce Mary O'Mara to present. She will be presenting today innovative responses to carers during COVID-19 to online early intervention mental health programs. Just a little bit about Mary. Mary is an experienced counsellor worked at Carers Victoria for 21 years. She has an interest in developing and implementing evidence-informed practice that targets the stages and the impacts of a carer's journey. So I'd like to take this moment to pass over to Mary. Welcome, Mary.
Thank you very much. Thank you, Matthew. And thank you for having me here this afternoon. I would just like to begin by acknowledging the traditional owners of the land on which we all meet, and to pay my respects to elders past, present, and emerging. So this afternoon, I'm going to talk to you a little bit about two programs that were developed initially face-to-face and have been taken online. Both of these programs have a focus on the impact of carers' mental health and well-being, and were funded by the primary health networks from the Western Regional area of Victoria and also from the Northwest metro region of Melbourne. The first program is called Mind the Step, and that was to address basic mental health literacy and help carers perhaps recognise the unrecognised impact that caring can have on their mental health and well-being. That was presented in a psychoeducational format. The second program that I'll speak to you about was called Carer Wellbeing and Connection, and that offered a slightly more therapeutic option for exploration and reflections around the impact of isolation and the benefits of connection. Now, Mind the Step round 2, the second round of funding, and Carer Wellbeing were all ready to go just as the first lockdown hit. So this presentation will focus on the challenges of moving both programs to online delivery and not so much on the content of the programs. As you can imagine, there were many conversations within the team about how or if we could possibly proceed. And this structure that you see, thank you for changing the slide, Matthew. This structure is the way the sessions were eventually delivered online. So there were weekly 90-minute sessions over 4 consecutive weeks, delivered on Zoom, facilitated by a mental health professional plus a moderator, and they were internally and externally evaluated. Thanks, Matthew. Next slide, please. So we proceeded, not without some trepidation, I have to say, and as the content developer and the lead facilitator, most of the trepidation was mine. Would anybody sign up to do this online? Would they have the technical capabilities? Would people engage online? And so to test this, we undertook Codesign, including calling people to gauge interest in online delivery and in the program content. How would we manage privacy and confidentiality? How would we manage online etiquette? Considering some of the Zoom programs I've been on, we thought it was important to refer to this. Will we be able to talk about topics, sensitive topics online that may trigger strong emotions? And how would we manage those triggers? How would we ensure safety? How would we clarify that people were really engaging and in the discussion and in the reflective conversations, which are crucial to allowing the themes and the issues to unfold? And one of my real concerns was how we would allow enough time to do this without creating that online fatigue that I'm sure most of us are familiar with now. I was also aware that the incidental connections and socialization that happen in face-to-face groups, usually around lunch breaks or coffee breaks, would not be occurring in this for the obvious reasons that we wouldn't be having those together. But I guess for me, the main concern of all was that I hadn't ever delivered online groups before. I had done some individual work, but not groups. Thank you. Could I have the next slide, please, Matthew? So we pivoted from what was well designed and thought out to how would we change this to an online delivery. Mind the Step was originally designed to be delivered face-to-face in 3 2.5-hour sessions to between 8 and 15 participants. First of all, the time had to be reduced to 4 1.5-hour slots, and the numbers were capped at 6 or 7. Carer Wellbeing was originally designed to be delivered as 9 2-hour sessions with about 5 face-to-face and some telephone support and follow-up sessions, with a maximum of about 10 participants. This time also had to be reduced to 4 1.5-hour sessions and numbers capped at about 7. The reason for capping the numbers was to allow everybody to have the time to have their say, to tell their stories, and then to allow the crucial aims and purposes of the sessions to unfold. 2 staff, a facilitator and a moderator, were required for each session. And to meet our target numbers, we had to run more concurrent groups. And obviously, as well, I had to train extra facilitators and moderators to help us with this. Thank you, Matthew. Next slide. Both programs had been run simultaneously by me, which allowed for testing and ongoing learning. So this helped with the continuous improvement. Back at the end of each session, an evaluation by our partners also enabled continuous improvement. In both programs, I think it's fair to say that some exercise had previously been incorporated that required more time in a psychoeducational format and in a therapeutic format around self-discovery and acknowledgement of the impacts that caring has on carers. And instead of doing those in a practical way, much of that content was then absorbed into the discussions and the reflective conversations that we had with the participants. So retaining the salient topics of understanding and acknowledging the impact of stress, anxiety, and isolation on a carer's health and well-being was reiterated and reflected constantly throughout the sessions, and also supported by the handouts that were sent weekly and the strategies that were provided for managing these. And I think working in a sequence and building on each session really enabled me to retain the integrity of the program. And of course, the adaptation of training and supervision for the other facilitators contributed greatly to the success of the program. And I have to say that I felt the content was not compromised at any point. And targeted content also allowed us to reach different cohorts. We ended up running 2 all-male programs and 2 cold programs for Vietnamese speakers. And it was interesting that hardly any changes were required to the content, either for translation or for delivery online. Both programs were independently evaluated by the University of Melbourne and by Think Impact, which also contributed to any improvement that was needed. Excuse me. So next slide, please. Coming back to the main issues for me, duty of care was something that I was not convinced could be managed too well online. I was proved wrong, but I was concerned about it. So we were really clear that preparation for staff and participants would be a vital factor of taking this online. And to this, what we did was we actually screened every participant who had submitted an expression of interest to ensure that the program was appropriate for their needs, to ensure that group work was appropriate for their needs and that maybe they didn't require individual work at that point, and so that they also understood the interactive nature of the sessions. It wasn't so much me just talking at people. It was really important that they understood they would be invited to speak to it as well. These screenings and conversations really helped us to explain the importance of ensuring safety and privacy in the sessions. And so potential participants were informed that they would require to be somewhere quiet, a quiet spot where they would be uninterrupted. They could use headphones if they wanted to. And we requested that participants kept their camera on throughout the sessions, unless there was a very good reason why they couldn't. And those of you who will be familiar with counselling or running groups will understand that in face-to-face you get whole body cues, you get clues, you get, you know, a lot of information, non-verbal information. And one of my concerns was that I would not have this, because what I was seeing was only the top half of the person, and in some occasions I only saw the tops of their heads. So I was a bit concerned that that might be missing. We also, as a team, ran some Zoom training for participants, so they were familiar with the technicalities associated with the sessions. And we interviewed and we trained appropriately credentialed facilitators and moderators, and the moderator acted as a second pair of eyes, and I'll speak to that a bit more in a moment. And we also offered weekly supervision. I offered supervision to each facilitator, and the team supported the moderators, and there was time to debrief after each session. And during the sessions, SMS reminders were sent to all participants, and weekly emails with the handouts were also sent. So you can already see that even prior to the program, there was a lot of work to be done. During the program, we had the excellent moderators who were available for tech support. They ensured that the participants got on okay, they were able to be heard, they were able to be seen. More importantly, they could hear and see us. And that support was there for them throughout each session. The moderators also followed up with anybody who might have been late, to clarify what the reason for that was, and also if there was a non-attendance. But more importantly, I think we used the role of the moderator as someone who could actually follow up with somebody if they seemed to be distressed. And then they would offer a phone call from the facilitator to ensure that the participant was supported appropriately. And participants created that safe and non-judgmental understanding space themselves. And in almost every session, participants spoke about how safe and supported they felt, and many spoke about this being the first time they had disclosed certain information. And at the end of the program, support details were sent and appropriate referrals on were made when needed. Next slide, please, Matthew. Thank you. So these are the groups that we have run to date. As you can see, 54 programs with 216 sessions over the last 12 months, and we've reached 250 carers in Metro Melbourne and regional Victoria. And I'm not going to speak to that too much more. It speaks for itself. Most important thing in the next slide, thank you, what we learned. First of all, what we learned online is not a quick fix. There were the more obvious things, that it required great preparation, but it also facilitated ease of access and responsiveness to carers. We offered evening sessions and morning sessions and afternoon sessions, so we were very flexible in our offerings, and that allowed us to access carers who would otherwise not have been able to attend, maybe if they were face-to-face, due to caring commitments and geographical distances. Some of the more surprising learnings that came out of it were that the content and delivery style transferred really well to online, even in the specialist groups for the men and the Vietnamese speaking groups. My concern was around some of the bodywork strategies that we might use to manage stress and anxiety, but there was no problem with that. And as the sessions progressed, facilitators and moderators uncovered similar dynamics and themes in all their groups, and we learned to manage those as we proceeded in our supervision sessions. Another thing that we hadn't thought about but proved to be a real blessing in disguise was using consistent facilitators and moderators, because that enabled people to become more familiar with it and to see where things perhaps were not working. Something that really hadn't occurred to me, and you would think this was fairly obvious, was that I hadn't realized that we would be in the carers space. I'm used to people being in a neutral space or sharing, but we were in their space. And that offered us a window into their lives, which was sometimes challenging, but it was very different to be in their space. And I guess you could say that, yes, the internet dropped out, and yes, the images froze, and we managed even the earthquake, but we did manage to complete every session, and carers' feedback was really, really positive about the whole thing. And also carers shared their online details and continued to catch up with people afterwards. So I'll go to the next slide. Thank you, Matthew. This is the feedback from carers that we have received, and you can see that they refer to some of the things I've talked about to you today, and also that there seems to be some really positive feedback about the content and about the online delivery from carers. So Matthew, there are 2 slides with feedback from carers. I don't know if you want to go to the second one when you're ready. Done. Sorry, a bit hard to see it. Thank you. Okay, so I don't know if we have any questions. If not, if you want to find out more, it's on the next slide. If you would like any further information about the programs or about Carers Victoria, we'd be happy to chat to you at any time. So thank you very much.
Thanks, Mary. We do have a couple of questions. We've got about half a minute to go. I just wanted it was great presentation. A lot of people were sharing similar situations and experiences. One person said, it's nice to know you've had the challenges for people doing this on short notice. Question is, have you estimated the number of potential clients you would have engaged in the program? And will you continue to offer this program once face-to-face delivery resumes?
Thank you. Good question. Yes, we have already reached over 250 carers, and we have 3 groups remaining to be run. And I think this is not going to replace face-to-face groups, but it is an additional tool that we now have in our toolkit, and we can deliver it online if required.
Wonderful.